Now, the plan for the day is to look at the report first in some detail. And one thing when I talk about the report, I'm talking about the report officially. I'm not talking about the report from my perspective, because that's not the way we do it in the National Academy of Sciences. When we produce a report, it has been highly vetted and is a consensus report of the panel. And so we can't speak for any one individual on the panel or any individual panelists say something about it directly when reporting on it. So the first part of my talk will be basically summarizing the report itself and how it came about and some of the details in it. Then I will move to the public policy implications, situating it within the American perspective and an international perspective, and move through a slightly different plan of approach. So that should be understood, that when I talk about the report, I'm not necessarily reflecting all of my values, but I'm reflecting the values of the panel. So let me say something about the National Academy of Sciences. I think I want to go back one. Was it? No, it's coming up here. Well, this is the report. And a lot of the presentation that I'll make that relates directly to the report refers back to a Senate briefing, the official Senate briefing that was done in January by Stephen Wolfe, who is the head of the panel on understanding cross-national differences. I'll put a little bit of perspective on this. The National Academy of Sciences, by American standard, is quite an old institution. It goes back to the middle of the 19th century. Under President Lincoln, as you'll recall, in 1863, there was some unhappiness among the states at that particular time. But the National Academy was still established at that time. IOM, the Institute of Medicine, is more recent, 1970s. This project was requested and funded by the National Institutes of Health. And it had to be approved by the governing board of the National Research Council after looking at it from the standpoints of bias and conflicts. 9 experts worked on this pro bono. That means we didn't make any money doing it. We were just paid to come to Washington and to write things, but no direct income associated with it. And the project itself was, of course, highly vetted. I cannot tell you, unless you've worked on one of these projects, how strongly these are vetted, because there were at least 16 major reviewers of the final product, giving extensive comments. And then there were every agency of government that could be related to this, like the CDC, the National Institutes of Health, had to vet it as well. So it's important to know this, because therefore every word in here that sounds, if there's a word in here that sounds provocative in the report, it's because everybody agreed that it was okay. Also, I was not allowed to be on the panel initially because I was still working for the government, and that's something to keep in mind. You can't be a panelist at the National Academy until you cease working for government, but I retired at the beginning of this and therefore could be invited to be on this panel. The panel itself is a mixture of people. It's pretty, I think, except perhaps for myself, there's some pretty smart people on this panel. We have a number of people from the other countries, particularly Mackenbach from Erasmus University in Rotterdam, who's done a great deal of work related to this, and Kari Christensen from Denmark. The panel was balanced between 3 types of people, really. Epidemiologists, social epidemiologists largely, such as Paula Braveman or and others, social epidemiologists, sociologists, and demographers. As far as I know, none of these people have a medical degree, but they might. One might have slipped in. I don't know. But Stephen Wolf, who was the chair of the committee, did have a medical degree. And we had a very good staff. So this was a production effort. To produce this document really takes a lot of people, a lot of time. So we worked 18 months on it, multiple meetings, went through an enormous amount of literature, had special preparations done for us, had people like invited in to talk to us, like Michael Marmot and other people of that sort, to make certain that we heard what we needed to know. But the basic conclusion is this, that the US spends more money than any other country in the world on healthcare per capita, and its life expectancy is lower than all the other developed countries. What you see here, if you're a regression type person and you like those things, it looks almost like a regression fit line here, that basically as you spend a little more money, your life expectancy goes up. Although Japan may be, Japan here may be a little bit of an outlier, but they're very healthy anyway. But the US is really an outlier. They're way over there. So for the panel, this is kind of a basic question. Well, why is this? Because there are a lot of people in the world who believe that if you spend a lot of money, you get value. You know, that if you spend a lot more money for a car, you get a better car. That's what you would expect. And clearly that isn't working here. The structure of the report was first to document this health disadvantage in detail, in enormous detail. The second part was to try to explain it. And the third part was to put forward future directions for understanding the US health disadvantage. Each of these had a different kind of challenge. Documenting the US health disadvantage was probably the easiest because there was an enormous amount of data available, although it still had a lot of problems. Explaining the difference, of course, that's the real problem. And we went into some detail to do that. And future directions is a little more speculative. The first part, documenting the health disadvantage, we looked at mortality, morbidity, and health across the life course using the common approaches that are used. We looked at DALYs and all those kinds of things. And incidentally, while this report was being done, we did not have the documentation of the later DALY work that came out in the Lancet just in the last year or so. But it doesn't make any difference because the data remain basically the same. We had 17 peer countries, comparison countries. We wanted to look, for comparison, we wanted to look at rich countries and countries that had well-established healthcare systems. We were not interested in how the US did against Mexico or Colombia or India. We were interested in what do we look like compared to all those extremely wealthy countries. And so these were the 17 peer comparison countries that we looked at. When you look at mortality from non-communicable diseases, you can see the age-standardized death rates per 100,000 people. Of the 17 peer countries, the US had the second highest mortality from non-communicable diseases in 2008. That hasn't changed too much in the new documentation as well that's coming out of the University of Washington and the Murray group. So this stays basically. Denmark always was a kind of a sore spot for us. We really didn't know what to do. It didn't work in quite the way we had hoped it should, because many of us thought that the US might have been the lowest, but Denmark surprised us on this. Those of you, if there's anybody here who has Danish theories on this, you can introduce them in the discussion. When you look at communicable diseases, infectious diseases, The U.S. also has a pretty bad picture, the fourth highest infectious disease rate, mortality rate, and the highest incidence of AIDS, third highest in the OECD. And if you look at this, you can see, and those of you who are interested in Canada, Canada is always in these pictures. What I won't say too much about Canada because you can draw your own conclusions, but Canada always kind of lies in the middle of all the data. I think that's trying to tell you something about Canada, but I'm not certain what. That can be speculation. Death rates. As of 2009, ischemic heart disease mortality in the US was males was higher than all peer countries but Finland. Here's another one of those outlying Scandinavian ones, and Finland has a peculiar record with heart disease. And then it basically looks like emerging economies like Mexico and Slovenia. Now when you look at some other areas, we looked at injuries, of course. Injuries, again, Finland is the winner here, if you want to look at it that way. But injuries, again, you get this, among the 17 peer countries, the U.S. had the second highest injury mortality rate and had the highest death rate from transport accidents. But when you look at this one, the next one, we really do very well. The 69% in 2007, and there has not been much change in this, 69% of U.S. homicides, 73% of those before age 50 involve firearms, compared with 26% in peer countries. The homicide rate was 7 times higher than these other areas. The rate of firearm homicides was 20 times higher than in the 22 OECD countries. And although the U.S. suicide rate was lower than other countries, the firearm suicide rate was very high. So there is a gun culture operating that accounts for a lot of deaths. Life expectancy at birth. U.S. is, for males, has the lowest life expectancy at birth. For females, the females just trump by, these are very small differences, Denmark. Denmark, again, is often an outlier. We did speculate a lot about whether we should say much about Denmark and Finland. But one thing that is quite clear and that everybody recognizes, that Denmark and Finland, they're both very small countries compared to the U.S. So there may be if we actually looked, and we talked a lot about whether we should look at state differences in the U.S., internal differences, but we backed away from that because it was problematic enough to deal with national differences. Life expectancy at birth. For the 20 high-income countries, you can see the U.S. lines running. Of the 21 high-income countries. The problem, what was apparent when we looked at the data, this is over time, is that what we were looking at was long-standing and worsening. Everything we looked at showed almost the same pattern when we looked at diseases. Not only was it substantial and long-term and lasting over a long period of time, but it was getting worse. The same when you look at the probability of survival to age 50 in the high-income countries, and there the U.S. does particularly poorly. American youth have been less likely to survive to age 50 than people in all the other rich nations. So there is a pattern here of really not very good outcomes. And under 50 was a particular group that we were interested in. because a lot of people have looked at the data of over 50, and that's been explored a great deal, but not really examined the under 50. Carrying on with that, if you look at years of life lost before age 50, U.S. male and female newborns can expect to lose about 1.4 years and 0.8 of a year of life respectively before age 50. So the U.S. losses of life before age 50 are double those of Sweden. So things are looking pretty good up to this point. Infant mortality, same picture. Also, these are long-term trends too. This is just looking at it over a period of 2005 to 2009. But infant mortality rate is quite high. It did decline between 1990 and 2010 by 20%, the infant mortality, but other high-income countries, most of them halved their rate during the same time. Children's health disadvantage. The probability of children dying before the age of 5 is higher in the U.S. than in the other 16 peer countries. In 2006, the U.S. had the highest rate of child deaths due to negligence, maltreatment, or physical assault. The rate of violent deaths, very high, and so on. So you see that there's a real strong picture emerging here. U.S. adolescent disadvantage. Among teens, age 15 to 19, the U.S. had the highest all-cause mortality rate among peer countries. This is a decades-old pattern. Obesity, of course, is another problem to look at. Obesity we didn't worry too much about because actually, well, we worried about it, but obesity was a problem that was pervasive as well, but it is later than a lot of these other patterns in appearing. Adolescent sexual health, interesting one. The U.S. has the highest teen pregnancy rate among peer countries, 3.5 times the average of the peer countries. Prevalence of syphilis, gonorrhea, and chlamydia higher in the U.S. than in other high-income countries. So not all Americans evidently are staying pure in their adolescence, for those who worry about those things. Injury mortality, same thing, highest rate of injury mortality rate. Since the 1950s, transport injury mortality at ages 15 to 24 has been higher in the U.S. than in the 17 peer countries. Youth mortality from violence. Since the 50s, males aged 15 to 24 have been more likely to die from violence in the U.S. than in 16 peer countries. This is highly gun-related, firearms related. So the adolescents and the people who are younger are not doing too well either, which would argue that what we're seeing is a disadvantage that's going to continue in the future. It's not a disadvantage that was based on people from the past. Age 50 and above presents a slightly different picture, but if you look at the conditions in the U.S., all of these are more prevalent. When we look specifically at diseases of over 50, there was some good news. The U.S. actually does a little better with cancer mortality and stroke mortality and control of blood pressure and cholesterol levels because they're a heavily medicated population. U.S. does a little better with suicide, a little better. I mean, by that they commit a little less suicide, especially the over 50s. And elderly survival is quite good if you make it to age 70 or 75. Your survivability then is pretty good, which makes sense because everything else before has died. So there's a fundamental logic to that. If you get through all this, you're probably going to continue. Self-rated health is very high in the U.S. The U.S. this is a pattern that always emerges, that people think that they have great health. The 9 areas of disadvantage, however, are just to recapitulate, injuries, homicides, infant mortality, adolescent pregnancy, STDs, HIV and AIDS, drug-related deaths, obesity and diabetes, cardiovascular disease, chronic lung disease, and disability. All the major diseases. And even with the cancer slight advantage, it's a pretty small one. So that's the picture we had after looking at all the data for a long time. This is what we included. Then, of course, the hard work started. Well, that is, how do you explain this? There was a lot of discussion about this, as you can imagine. We certainly felt that we looked at morbidity and mortality in the first 2 chapters of the book. And if you, the book, incidentally, is available free on the web. So I urge everyone to look at it as much as they want to. You can buy it as well, but it is free. So we decided, what are the usual suspicious characters to explain the U.S. health disadvantage? Well, we've got health systems, the health system. We've got to look at health care, individual behaviors, social factors, environmental factors, and policies and social values. This is where things get very sticky, and where it becomes, and when you read the report, you'll see how this was discussed in so much detail, that I don't think there was a panelist there that didn't believe that all of these things were causal. And the arrows were going in all directions. But the nature of literature in the field is reductionistic. And so you can find a great amount of literature looking at individual behaviors and outcomes, health systems and outcomes. Even some literature on social factors. When you get into environmental factors and policy and social values, the so-called evidential base becomes much more problematic. To say anything. We wanted to say things that were evidence-based. Individual behaviors, there's a lot on that in the book, but this is just a piece of it. I just chose this one, firearms per 100 people in the U.S. There's limited data available, cross-national evidence about injurious behaviors, but possession of firearms is something we know quite a bit about, and the U.S. Does very well in firearms ownership, as you can see. Switzerland has a high rating because it's mandatory that Swiss citizens have a gun in there to protect, I guess, snow slides or something. But I don't know what, but at any rate, sorry. That's not an official comment from the government. We didn't look at snow slides and firearms. But anyway, you can see the U.S. case. The other thing is that U.S. motorists are less likely to fasten their seatbelts in the front. And many states, of course, in the U.S. don't require seatbelts to be used on pickup trucks and various other kinds of vehicles. And a high alcohol rate of road accidents. Motorcycle helmet use is often discretionary in states. Social factors, well, now you start to get into the tough ones. Has the highest level of income inequality among the peer countries. Since the 80s, it has had the highest relative poverty rates among peer countries. Just a slight explanation about relative poverty rates. Many countries, when you look at the data, like Germany, for example, France, start out with about the same population that's poverty challenged. But there's a social welfare net that takes that disadvantage away. So that's what we mean by highest relative poverty. And we've had, since the mid-'80s, the highest rate of childhood poverty. public policies. Studies suggest that the style of governance may influence health outcomes. This we looked at in some detail. And I suggest you go to the book to read this, because actually there's a lot of information on this. And it isn't as clean a literature as you would like, but it's quite interesting. And there's a general feeling that in the literature that countries with a social democratic model of governance, for example, Scandinavia, tend to have better aggregate health outcomes than countries with liberal models. Liberal, like in our classification, we consider the UK and the US and Canada actually as well. Liberal in the classical sense of liberal, not the left-wing sense. Studies report also an association between social spending and life expectancy. Here's a really nice one. This is a graph of average health services expenditures of GDP, and then on the y-axis here, the average social services expenditure as a percentage of GDP. And here you can really see that most of these Scandinavian countries lie quite high in social expenditure. The US below the line. And if you look at the ratio to health services expenditures for the OECD countries in 2005, you see that the US is way down in terms of the relationship between social expenses and health expenses. And Canada is 2, just to let you know that. So all of this brought us then to looking at all this. We looked at future directions for trying to understand it, and we put forward recommendations for research and recommendations for policy. I won't follow all of these recommendations because they're all available in the book. Of course, the recommendations for research were partly, we tried to stay away from the classic line that more research is needed. But looking at all of this, it was clear that more research is needed of particular kinds, and specified who should do it, and we made specific recommendations to the agencies of government like NIH and CDC that should take up this kind of research. But they're just recommendations. The panel has no power to pass legislation. So these are just recommendations. And we have recommendations related to policy. Let me take one of the policy ones. Number 4, the nation should intensify efforts to achieve established national health objectives that are directed by at the specific disadvantages documented in this report. Interestingly enough, the U.S. has a really comprehensive plan, Healthy People 2020, which follows from Healthy People 1980, 1990, 2000, 2010, 2020. I was on the area I was in charge of the area of Healthy People 2020 for the U.S. that looked at social determinants of health. And so the 2020 version has a lot more social in it. But basically, if just the recommendations that are laid out in the Healthy People were carried out, that would be really substantial. We think it would have a substantial change in the kinds of data we're looking at. Another recommendation was to alert the public. And this is something that can come up maybe in the discussion, that when you have a big report like this, how does it engender some kind of a discussion in the public, in the media? We've had a lot of media coverage, but you're not quite in control of the media coverage, and it may not cover exactly what you want it to. But at any rate, we did say there was a real need for a comprehensive dialogue in the country about why this is the case. I mean, I think that it's, if you have something that is pervasive and continuous, if you pervasively and continuously perform poorly when you're spending more and more money than anybody else, you should probably discuss it. And we, of course, had a lot of recommendations specifically to institutes to look at policy options in the U.S. and to look at our policy options in other high-income countries and what those policy options seem to do to make them perform better. So I don't expect you to write this down, but you can just go to the web and put in this report. Just go to the IOM and you look at reports and you'll see this. It's worthwhile to read the whole document. It doesn't take that long. It's only a few hundred pages, so it's not bad. So that's the end of comments directly from the report. The following comments are based on questions out to the presenters by the organizers of this, out to the presenter, that being me. Get that clear. Put forward by the organizers of this presentation. And so as I said before, it's important to distinguish the work of the panel from the comments that follow. And now I leave the report for a bit, but what I will be saying is mostly all influenced by the report and other documents as well. Situating the health status of Americans within an international perspective, I was asked how useful this is. I think it's very useful to do this kind of work. First of all, almost all of these countries that we compare ourselves with largely share a Western-style system of medicine. There's no, there are no secret forms of medicine going on. Everything is allopathic. The approaches are very similar. If you go to a hospital in Germany, or to a physician in Germany, the approaches will be pretty similar to what you would get in Canada or the US. Also, it was quite clear in doing this and in our discussions with outsiders that many Americans view their health status and health system as the best. And this was always a kind of a conundrum to us when you remember the debates about health care during the Health Care Act that passed under Obama, that continuously there was almost no comparison made with other countries. And when that comparison was made, the other countries were always seen as inferior. The comparisons, Canada was used occasionally. The UK was used, but they have socialized medicine there. I mean, so that really wouldn't work. Some countries it might have a mixture of types of medical care, like Germany, that's kind of a public-private cooperative kind of system. Would have been very good comparisons to look at in the view of myself and many others, but this reality does not seem to enter into the daily discussions that take place in discussing American medicine. And this remains a conundrum, and I think it's a very interesting. We try to think. That's why we had a recommendation for a dialogue, that something should take place to change this discussion of continually viewing that we have the best system. I can just give you one quick anecdote. I was at a conference. I wish I remember my phone. I was at a conference public health conference in Washington, D.C. Sitting next to me was Marie Claude Lamar, who is the executive director of the International Union of Health Promotion, based in Paris. And on my other side was another guest of mine, Camus, who was the then head of the NCD area at WHO, she was also a Parisian. So I had two French. The then Secretary of Health opened the meeting by saying that we had the greatest healthcare system in the world. And he said people come from all over the world to use the healthcare system in the US. That's probably true. And then he said they certainly wouldn't go to France. So I sort of got shorter in my seat between these two French women and thought, I apologize, this is our Secretary of Health, what can I do? In fact, at that time, the WHO had ranked France as having the best healthcare system in the world. But that's a minor point. Evidently, Like me, the Secretary of Health doesn't read French, so didn't know. But at any rate, what is interesting too in looking at these other countries, I think, are that there are some reasons that should encourage the American government to take action. There are observable structural and functional similarities within these countries. That's why these comparisons, I think, are so important, because many of these countries actually look a lot alike, and a lot like the American healthcare system if you pull back from it a bit. And when you look at the actual structure of hospitals and the care systems, the differences are not so great. Where the U.S. has also done pretty well is where they've taken broad public health action, for example, in screening. Screening for breast cancer, for cervical cancer, and screening for colon cancer. The cancer area screenings have been really evidently quite effective, and the U.S. has done well. Those could be even changed and improved in other ways. At any rate, one of the things that became clear in this, from my perspective, is that the healthcare system was the least important area to look at if you want to explain these differences. What happens is that most people want to go to the healthcare system immediately because that's where that's the thing they know the best, perhaps, and it seems logical to do that. But actually, the evidence of differences in healthcare systems to account for the disadvantages in the U.S. is really small. So the literature, the healthcare system per se, by that I mean hospitals, physicians, and so forth. We have less GPs, general practitioners in the U.S. than we might have. But basically, it's not such a bad picture compared to these other countries. So from my perspective, I think that we should stop looking at the healthcare system as the source of problem, of disadvantage here. I'm not saying to abandon looking at the healthcare system and improving it, because we pay far too much money for the healthcare system we have. But that has many causes and reasons that really don't have so much to do with the healthcare system per se, as it may have to do with pharmacy industry and other aspects. But it's clear that probably looking in the direction of healthcare services as a solution to the problem is not going to take us very far. What I think is most important, of course, is that about this comparative study on the health impacts and public policies is that this really reveals contextual factors. All the other things that are important in determining what kind of health outcomes one sees. But here we got into a lot of trouble because many of the variables that could be of use to compare countries are not there. Most of the data are largely based on individuals or individual behaviors. Policy variables are very problematic in comparing them across countries. And in fact, one of the things that became clear was that, and this is one of the pieces that we called for in research, that more research needed, that the research is needed in different kinds of measurements and different analytical techniques. There's really, when you go into comparative, when you go into comparisons, it's hard not to be comparing apples and oranges. And when you look at these big data sets, you don't have to look very far into them to see that some of the times what you think you're comparing is not really the same at all. So methodologically, there are lots of problems with this kind of approach, particularly when you go to the contextual factors. I call them contextual factors. Some people call them social factors. Some people call them social cultural factors. Some people call them social determinants. There's a big group that go the social determinants of health. I particularly don't believe in social determinants of health, but that's another discussion. So anyway, many variables could be used to compare. A drawback then is Also, another drawback is the lack of understanding the variation within the nation. One of the things that we couldn't grasp, because we would have needed another 10 years to do it, perhaps, or certainly another year, is start breaking the nations, because we were using as a key variable comparison a nation state. So you say, can you really compare Finland with the United States? You know, Finland may be worse in something than the United States is, but what's Finland? As we would like to point out, the city I'm from, the city of Atlanta, has a GDP that is the same as Denmark. So one city in the U.S. is Denmark, you know. And what's California compared to Texas, compared to Oklahoma, New England? You know, it's a big country. I'm sure you can appreciate that. You're in a big country too. I know that there are some Canadians who think there are differences between different parts of Canada and the way they perceive things. And in the U.S., that's really the problem. And so you have to ask, well, how much do you break down, go inside all these nations and say, can you break down, can you find the factors inside in the inter dimensions? And maybe the explanations are hidden in there. Maybe something will pop out from Iowa or someplace that explains most all the differences. We didn't have time to do that, and most of the literature is not organized this way. It makes sense, because we would then have the same problem if we were comparing Germany with the United States. We'd have to look at, well, is Bavaria in the south of the U.S. the same? Is Bavaria Texas and Hamburg New York? You know, this is a fundamental problem. We did discuss this, and we just sort of avoided it. We said, we can't solve this problem. Somebody else has to solve that problem. So if the reasons for these differences are embedded in within national boundaries, then it's even more complex than we thought. And we thought it was pretty complex. We talked a lot, particularly in public policy. There is a chapter in there, chapter 8, I highly recommend, on values and ethics and all these kinds of areas. And to put these public health concerns about inequities and the disadvantage the U.S. has and the efforts of public policy to reduce inequalities, there was a lot of discussion about this, because this cannot be a scientifically based argument based on the science we have. It's an moral ethical argument if we want to invest in better policy. It's not, one thing that's quite clear, we can't prove it. We can't demonstrate it by looking at the data, because we can't find the ethics in the data. You know, it's a big problem. So, from my perspective, I think that we have to look at that argument. And one of the things, if we're going to reduce inequalities, one solution I think of, because so much evidentiary-based work shows that some associations, the effect size is very small, that maybe we have to go to an ethical commitment of something like that. To reduce inequalities, we'll just try to do those things that don't do any harm. And that's the fallback position. The other thing is that we assume, many of us perhaps in this room and those of us in the public health sector, assume that the relationship we've been looking at and that we see is one that's between equitable societies, I should say, and better health is causal. You know, it's an assumption. It's not a fact, but we assume that the more equitable societies produce better health outcomes. This report cannot prove that, and whether any data that is available is probably one of the biggest and most difficult questions we face. Finally, some general points for discussion, and that is, first one is, what is the balance between more research versus action? There's really a debate that's plausible. that we shouldn't do any more research, any more basic research. We should only do implementation, we should only do research that is action related, and we do research on those actions to see how we can improve things. That we don't need any more studies this type, or the social determinants of health, the commission report. We don't need those anymore. We have all of the basic data we need. So the argument is that everything now should either be analysis of that or action-based approaches to address what is there. And what is the balance between this? I think this is something that each person has to take up on their own. And then, of course, the big conundrum also in this area is that if fundamental causes are at the social system level, because basically at the end of the day, what all of this that we did, and what all of the studies like the social determinants and others show you, is that actually the cause is way downstream for this health difference. And it's at the social system level that you're really talking about changing the underlying political structure of a country, our basic policies. And then you can argue that if they lie primarily outside of the domain of public health, what should public health people do? Because all these changes seem to be that are needed are outside the sector that we work in. So perhaps we shouldn't worry about this problem as public health people, because it's not in our domain. And we don't have the training or equipment to do anything about it. So let others do this. Non-governmental organizations, civil society. Sit back, enjoy being an epidemiologist collecting endless data. And just enjoy it. Producing, as we like to say, Himalayas of carefully analyzed data, untouched by human thought. So this is a real thing to consider. You know, why should those of us waste our time trying to change something that we don't have the skills to address, that we just have knowledge the problem exists? And finally, if you want to be really pessimistic, perhaps all these differences that we've been looking at over the years are simply secular phenomena. That's the way the US looks now. In time, in the longer run, the differences will switch around and go some other way. And the US will be on top. And Sweden will be on the bottom. And free enterprise and the American way of life will triumph. So that's, and that you can't answer. That's just a question to look at. So that's all I wanted to say about the report and some speculation on it and some contact information, and thank you.